Okay.
Where were you?
Let me first show the photograph.
Okay.
Okay.
So, Emilio, let me just tell the people that it was a long weekend.
No,
Wow.
come on. No way.
Yeah.
You go to Sweden.
I swear that this is today. This
3rd of
morning.
May.
This morning where? In Sweden, in Gothenburg.
No, in Greece.
Greece. Oh my God.
In Greece. Really?
Yeah. Impressive.
It's unbelievable.
Yeah,
Impressive.
of course, up on the mountains, up on a mountain, but still, this is, I mean, unbelievable.
Really.
Yeah.
Wow.
And I traveled with 7 Bofors. So
Impressive.
Yeah.
Allora, ragazzini. So we are today playing without Sebastiano. Yeah. So we will be a little bit sad, but anyhow, still lots of people connecting, Emilio?
Still, we have to say hello to Poland. And not only Poland, but also Turkey, Italy, Beirut, Romania, Croatia, Argentina, UK, South Africa, Libya, Ukraine, Brazil, Spain, Skopje, France, Canada, Hungary, Yoshkar Ola, which is Russia, we know now. Mexico. In Sweden, they have 20 degrees. Guys, what's happening? In Sweden, you have 20 degrees. In Greece, we have snow in 3rd of March. What is going on this planet?
Many crazy things.
Peru, Germany, Kosovo, Moscow. So hello, Athens. Hello, friends from all over the world. Today we have another nice episode, but I don't know why this season we decided to do all these strange things, because we are over of the
Yes, because basically we have no topics to be covered anymore.
Yeah, we have covered all the topics twice, 3 times. So yeah.
Great. So today we cover the unexpected results.
No, that's done.
Oh, sorry. No, of course. Disappointing results.
Disappointing. Still unexpected.
Yeah. Unexpected and disappointing.
It was disappointing, because in my mind it was unacceptable results. But it's it's close.
Yeah.
Yes. But I have a couple of nice cases to show you.
Okay. Then, since I have many roles for today, I have to be the anti-Sebastiano, which is very difficult. Before you start showing your cases, I have to show something more.
Okay.
I have to show something more. Which is this. And you like it? Music?
Yes.
I have to show music, yeah? Okay.
Without music.
Okay. Do you like it? Delta 30 UV. Let's.
Bellissimo. So this is
Space.
new, brand new.
Space Dermoscopy.
Sorry,
Constantinos, you are speaking.
sorry.
Don't worry, don't worry, don't worry. If we can help, we are here. If you need to speak with somebody there at the boat, we can support you.
Ok, ragazzi. So, Nisa, go ahead with your disappointing results.
Okay. Can you see my screen?
Not yet? Yes.
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 Yes. Okay. This is the case. And this is the clinic. There's a pigmented lesion in the ear, and my preferential here for sure, melanoma.
Melanoma.
Because the patient said that this is growing, this is a new one, and history is almost 3 years.
For
And
sure, this is a
dermatoscopy.
melanoma.
Yeah, this is a clear-cut melanoma, right?
Yeah.
It's a very chaotic lesion. It's inside the ear and looks highly atypical. And what can be the histopathology result, my dear friends?
Nevus.
Seborrheic keratosis.
Seborrheic keratosis, nevus. And Jeffy, what do you think about it? What can it be?
Well, if it's since this is a disappointing result,
Yeah.
it cannot be a nevus or a seborrheic keratosis because this is not disappointing.
Unacceptable
No.
result, or
Yeah. No, let's say this is really looking like a melanoma. Yeah.
yeah. And here's the histopathology report. You can understand even from the Turkish, it is pigmented basal cell carcinoma. And I translated the report,
No, come
and you
on.
can also
No.
read it.
Wow.
Come on. And I say, come on, it's impossible. It's not acceptable, unacceptable. And I directly called my pathologist and said that it's impossible. Come on, please. You should make an immunohistochemistry because this is not a basal cell carcinoma. It's impossible. Maybe the specimens can be mixed up, and please control all the things about the patient. And she said that, no, I'm sure about my diagnosis. And she sent me some histopathology photos. And here they are.
Okay.
And do you think that this is a basal cell carcinoma
Well,
with this histopathology?
well, not sure, by the way.
Not
But looks
sure.
like.
But this looks like nests.
Yeah, they are nests. The question is if they are melanocytic
No.
nests or basaloid nests.
Yeah, but they don't look like basaloid nests. They look like melanocytic nests, and
Yeah.
also pigmentation.
Yeah. We're not pathologists, of
They
course,
look
but
like melanocytes,
Yeah.
no?
melanocytes.
Yeah, they look like melanocytes.
Please do some immunohistochemistry and ask an experienced pathologist. And she said that it's okay. I will perform immunohistochemistry and consult the patient to my senior pathologist. And after all, after immunohistochemistry and after some consultation, histopathology was for sure a lentigo maligna here. So we should always be very careful with the pathology results, because if the patient go to another dermatologist and show the results that it's a basal cell carcinoma, and the dermatologist, if the primary dermatologist was me, but if another dermatologist saw the patient report, and she would accept and treat the patient as a basal cell carcinoma, which is impossible here. So another patient, look at this case. There was a very solitary lesion here, and it was very firm on palpation. And this is the clinical photos. And here's the dermatoscopy. We have branched and reticular vessels and a pink structureless background here. And what can it be? What's your preferential here?
Something infiltrative.
Yeah, it was very firm, like a rock on palpation, and you see a big mass here.
Yeah, something infiltrative like lymphoma or a deep infection.
Lymphoma.
Yeah.
Actually, it was easy for me because I knew the history, anamnesis of the patient, because the patient had a primary mucinous adenocarcinoma 15 years ago. It was diagnosed 15 years ago, and this lesion recurred at the same site. And since I knew the histopathology, I again took a biopsy, recommended biopsy from the patient, and the patient came with the result to me. And what can it be? It's very funny. It was a skin tag. Histopathology report
For
was,
sure, skin tag.
and it was really very weird for me. And again, I called the pathologist, and it's impossible. This cannot be a skin tag. Please look at the slides again. And she said that it's not skin tag. Come on, she told me. And this time, the pathologist informed me that they gave a result of primary mucinous, not primary, mucinous adenocarcinoma to another patient 1 week before, and the histopathology was taken at the same day. So she said that the results can be mixed up again. And what's funny is this mucinous adenocarcinoma result was given a professor of orthopedist from our hospital because he had a skin tag on his back, and one of my friends from my department excised it, and he was very surprised because when he got the result, he had the diagnosis of mucinous adenocarcinoma. And they were all shocked, the dermatologist and the professor of orthopedics. And my colleague requested him a PET CT, colonoscopy, endoscopy, all the things, looking for the primary of this mucinous adenocarcinoma. And the professor was so sad. And 2 days later, he will be, he is going to have a colonoscopy because of the surging for primary. And then we learned that all these results were mixed up, and he had a skin tag, and this was the mucinous adenocarcinoma. And I would like to show you the patient was given radiotherapy, and this is a 6 week of radiotherapy. And this lesion was unresponsive to the radiotherapy. And when I looked at the literature about the treatment of mucinous adenocarcinoma, it's really extremely rare, because we know that mucinous adenocarcinoma is generally metastatic, and there's a primary in the colon or rectum or gastric adenocarcinoma. So even my oncologist didn't know the treatment for this primary cutaneous mucinous adenocarcinoma. So we first try radiotherapy, and you see the result. There's no result. And the plastic surgery then excise the lesion. And this is the second year of surgery. I think this is really very good for the patient because it was really a very, very massive and very firm mass, and the patient was very happy with the result. So this is a really very rare situation, which is primary mucinous adenocarcinoma of the skin. And this is
I've
my
never encountered one in my life. A primary mucinous adenocarcinoma of the
me as
skin.
well. Yeah, it's extremely rare, really. It's very strange. So this is the third case, and the patient is a 50 years old female, and this pigmentation appeared 3 years previously and progressively widened. And we see a bluish, blackish longitudinal melanonychia here. And histopathology report was here a blue nevus, which is impossible.
Wow.
Because we know that blue nevus generally is a dermal melanocytic proliferation, and it's generally involving the nail bed, not nail matrix. And we see blue nevus of the nail as a structureless blue, especially located in the proximal part of the nail, not a longitudinal melanonychia. So this is impossible for this patient, blue nevus, right?
I think that what you're saying is very important. Exactly. So if
Yeah.
we have a blue nevus on the nail, which is of course very rare by itself, it will not end up into a melanonychia. It will only involve the proximal nail bed. It will not end up into a longitudinal melanonychia because it's a dermal proliferation. So accordingly, yes, exactly what you saw right now.
Exactly.
This is a blue nevus. This is a blue nevus.
This is a blue nevus, and so again, I talked with my pathologist, and she said that this really looks like a blue nevus. And I requested slides and asked this to Harold and Australia, Simon Clark, and also and Luke Thoma, and three dermatology departments and histopathologists evaluated the lesion, and it was really very difficult, very challenging lesion, because there was a heavy melanin pigmentation, as you can see from the slide. There's heavy pigmentation, heavy melanin pigmentation, and you cannot see the underlying structures here. So after some sort of bleaching, again, the structures are not very well recognized because there's an artifact here. But Luke Thoma and Simon Clark thinks that this is not a blue nevus, and this should be an invasive melanoma here. Really, they evaluated very carefully, and they looked all the slides and all immunohistochemistry. And after all, the patient was diagnosed as invasive melanoma with a breast of thickness of 0.3. So we should be very careful with these melanocytic lesions, especially which occurred at the age of 50 and which is enlarging. And this is a really red flag for melanoma, not consistent with a benign lesion. And when there is progressive band widening and variation in parallel lines, this supports the diagnosis of melanoma here. And we should always take second opinions for cases like this, if the pathology report is like blue nevus or a nevus. And we published this in our lovely journal, Dermatology Practical Conceptual, in 2017.
Nice.
And this is the last case.
Yeah.
Yeah, this is also interesting. The patient is 52 years old female. She was diagnosed with colorectal carcinoma and treated with 5-FU and oxaliplatin, and also with radiotherapy. And these lesions appeared in 2024, almost 16 years later, the diagnosis. And what's your diagnosis here?
Is the breast?
What can it be?
What is the location? Breast, right?
Colorectal.
Abdominal region. Colorectal, and this is abdomen.
Abdomen.
Abdomen. Abdomen. Okay, abdomen. Okay.
Abdomen.
That's the colostomy.
You see the colostomy back?
Yeah. That's the colostomy.
And this is abdominal region, and occurred 16 years later, the surgery, and the patient was treated with chemoradiotherapy.
Yeah.
It looks like angiosarcoma.
Very vascular. Very vascular.
Yeah. Angiosarcoma on the base of radiotherapy.
Perfect. This is a clear-cut angiosarcoma, right? But the pathology report here came as Kaposi sarcoma, which is not acceptable, right?
Yeah.
Because both the clinical presentation and dermatoscopy doesn't fit with Kaposi sarcoma. And again, I talked with my pathologist that please perform some immunohistochemistry, because here the diagnosis cannot be a Kaposi sarcoma. And after some sort of immunohistochemistry stainings, pathologists agree with me that this is a clear-cut angiosarcoma. So always clinical context history is very important, and we should always correlate our findings with histopathology, and we should have a good contacts with them. So these are my cases.
Nice, nice.
Thank you.
Wonderful, wonderful.
By the way, Nisa, what happened with this guy with angiosarcoma?
Died.
She was treated with I forgot to show you with paclitaxel, but the result is not very good. I think she is under treatment for the last 6 months. So
She's still alive?
I talked with my oncologist, and they will change the treatment because the response was not so good. But she doesn't have metastasis so far, which is good. But the lesions didn't regress with paclitaxel.
Yeah, angiosarcoma is a very bad one.
Yeah, it's a very bad one.
Yeah. I've no experience with angiosarcomas located elsewhere than the face and head where they usually are. So that's why I asked if location of the trunk changes anything.
Have you had any success in treating angiosarcomas on the face and head?
We don't treat them. They are
Oncologists.
Yeah.
I may have like
because they
first line is surgery anyhow, because if this is a primary lesion and there are no secondary locations, surgery is still the primary.
Yeah, but then the treatment is classic chemotherapy, so it's purely oncologic.
Yeah, but to be honest, I have maybe 10 patients, and all of them were operated on, except for the unoperable, and there was recurrence after recurrence, and eventually they all died, unfortunately.
Yeah. Okay. Costantino, but are you able to?
No. Constantino is on the taxi. He cannot share screen. So.
Okay.
Jeppe, go, Jeppe.
I go. Okay. Allora, this is nice because the first I prepared just 2 scenarios. The first one is perfectly in line with Nisa. Where is my? Here we are. Okay. Can you see my screen? Yes, I suppose.
Yes.
Okay. So basically, you see here the lesion. It's a tiny lesion on the arm.
A tiny blue thing.
Clinical diagnosis.
Yeah, blue thing.
Metastatic melanoma.
Come on, metastatic melanoma.
When we feel very pessimistic, it's okay. Yeah. Okay, so dermoscopically.
Blue
nevus.
Blue nevus. Okay, so
that's
this is a very tiny lesion, but I mean, come on, Lisa is right. Since this lady suffered from a 1.9 millimeter thick melanoma located on the back 5 years before, okay, my doctor decided to get this lesion excised, in order to rule out whatever, okay? Unfortunately, this lady was a little bit stressed by this fact because we gave, as you can see, we saw the lady on 8th of July 2025, and we made a reservation on 6th of August 2025, so only 4 weeks later, to excise this lesion. But since she was very stressed, she decided to go elsewhere to get the lesion excised. Okay, and she came back on only 2 weeks later with a diagnosis of melanoma metastasis.
Oh God.
Okay.
Which is a difficult one, I have to say.
Yeah, very disappointing, I would say. Very, very, very disappointing, because the clinical constellation is not really. suggesting a metastatic melanoma. First of all, because the melanoma was 1.9, not a big one, and located on the back 5 years before. And this is the only bluish lesion just appearing on the arm as a metastasis. There is wrong.
Like, I mean, pathophysiologically, there
Yes.
is no lymphatic drainage
No way.
that can
No
lead
way.
from the back
No.
to
This
the
is,
arm.
of course, hematologic disease, hematologic spread. But how can it be possible that an hematologic spreading is only occurring on the arm with a tiny lesion? So no way.
No way.
Of course, we asked for the slides. But by the way, the specimen was not very easy, because also for our pathologists, look at the prose, the way our pathologist was writing. He was saying intradermal melanocytic proliferation, HMB445 positive. Differential diagnosis between blue nevus and melanoma metastasis. Some morphologic features, namely the presence of dendritic cells and the absence of mitotic figures, are more suggestive for the diagnosis of blue nevus. However, the histopathologic findings should be interpreted together with the overall clinical and dermoscopic scenario. This is the key here, and in many cases that also Nisa showed, there are difficult situations in which only the complete assessment of the clinical, dermoscopic, and histopathologic scenario is able to make a final diagnosis. Here, our pathologist is saying, okay, it could be a blue nevus, but only if it's fitting with the constellation, and the constellation fits with the blue nevus. Okay, so it's not fitting at all with a melanoma metastasis. So of course, the lady is she underwent TC scan and everything was negative. So finally, we concluded with the diagnosis of a strange blue nevus.
Yeah, it's a very tough scenario. I remember a case very similar to yours, with the exception that in my case the location was relevant. It was in the regional area, but with a single thing. That was, as in your case, diagnosed as this, but then as that, and then a second pathologist saying the different thing. So yeah, in the end, we never learned, because she never developed any other lesion.
Okay.
So she's fine after many years. So what's the conclusion? Well, probably it was a blue nevus. Probably
it was a blue nevus.
but
Yeah. Another scenario, which in my view, I mean, I'm passionate later on this particular scenario, because it happened to me several times to have this kind of problems. So I'm going to show you 4 lesions, okay? So this one, okay? This is dermoscopy. Is this a BCC, yes or no?
well, could be. Not the most typical one, but could be.
It could also be a desmoplastic melanoma.
Okay. Second, is this a BCC, yes or no?
Same thing, could be.
Could be.
Most likely it is.
Could
This
be.
one, I'm more convinced.
You are all convinced here. Okay, good.
Yeah.
What about this one here? The lesion is this one. Okay, can you see my
Yeah,
we can see it.
yeah.
Okay.
SCC. Ah.
Yeah.
Now look at the dermoscopy. Is this a BCC, yes or no?
Yes.
Basosquamous.
Should be.
Yeah, basosquamous as well. Yeah, okay. And the last one, back. This lesion is located on the back. Is this a BCC, yes or no?
No.
All these are very, stressful BCC looking like lesions. Very stressful.
They're stressful.
Okay.
All of them. All of them.
I'm very happy that you say these are stressful BCCs, because the point is, when I have a differential diagnosis between BCC and melanoma, especially melanoma, of course, in these particular cases, I cannot allow that this lesion is going to be operated in 3 months or 6 months. As we do usually for BCC, we have a long waiting list for BCC. But when the differential diagnosis is between BCC and melanoma, we need to follow the path of melanoma. So 3 weeks maximum, because they were all melanomas. All of them. Okay.
All melanomas.
These are
The fourth one as well.
These are so
Wow.
scary. So scary. Okay. So this is really disappointing. Because if I send one of these cases to be excised in 6 months, it's a disaster. I will not sleep anymore. Okay.
Yeah.
So I
exactly.
have to find a solution. I have to find a solution because I work in a busy hospital where the surgery rooms are very busy. So I have to categorize the priority very, very well. When I have a clear-cut BCC, it can go in 3 months or 4 months, 6 months, whatever. But if not, I have to follow the melanoma priority. And in order to be sure about it, we are now testing this kind of algorithm. Okay, so the algorithm to differentiate BCC from melanoma. I can be sure for this algorithm that we are going to test anyhow. So we don't know, but I can be sure about the diagnosis of BCC if I have one of the positive features of these 3 positive features, which is the in-focus vessels, the multiple erosions, especially, of course, in superficial BCC, and especially in pigmented BCCs, if I have pigmented islands, so no pigmentation occupying the main body of the lesion. Okay, but contemporary, I need not to see. So I need the absence. So I need these 2 negative features to be absent, which is the presence of blue and black color, okay, and the presence of brown pigment as the main body of the lesion, okay. So if I see in a BCC with clear-cut, for example, here, I see focus vessels, okay? But I should not see this kind of brownish pigment which is connected to the main body of the lesion, okay? So this is a negative feature I should not see, okay? And therefore, even in a case like this, I cannot be sure that this is a BCC, and therefore I have to follow the urgent excision path, okay?
You should call it fast lane. Fast lane. You should follow fast lane. Fast lane.
Yeah, but
exactly.
Great approach, JP. I love it.
Yeah. Let's see. We are now testing this. So our mission, our aim is to demonstrate that this is showing a great positive predictive value. Yeah. And in order to a great negative predictive value. Exactly, negative predictive value, in order to be sure that if we say it's a BCC, in 99% of cases it's true. Okay, good,
excellent, fantastic. I don't see questions for the moment. So since there are no questions, I need to show you a video, and then I'm done with my tasks. I'm done.
Okay.
Because they create me stress, these tasks.
Yeah.
So I want to finish with them. And let's see this nice video.
Light as a serum, strong as an SPF 50+. Aven Sun Care Innovation Ultra Serum. An ultra light, undetectable texture. The most advanced sun care technology, enhanced with niacinamide and hyaluronic acid for an instant plumping effect. Ultra Serum by Laboratoire Dermatologique, Aven.
Wonderful.
Laboratoire dermatologique.
Laboratoire.
Havan.
French is so nice.
Perfetto.
How is your
Emilio,
French?
Is there Serbi Emilio?
So I thought that everybody, when we speak about disappointing results, I thought that everybody would show this. So I said, okay, I mean, I will not include this scenario, but you didn't. So thank God that I did include one case. So
Okay.
that, in my view, the most frequent scenario that we experience disappointing or unacceptable results. A case like this, in which you have a flat pigmented lesion with network and regression, with some kind of atypical network and regression, and then the scenario is this, the clinical scenario. It's an old guy with just this on his back, just this atypical lesion. Therefore, the clinical and dermatoscopic diagnosis is super easy, I think so, for everybody. It's obviously a melanoma in situ. And then you get the result of a dysplastic nevus or a nevus with moderate or
BCC.
ATP. That's super frequent, but I have to say that I'm not anymore frustrated by this. I'm not anymore.
Yeah.
Not anymore.
Me
I
neither.
live in peace. I live in peace with cases like this.
Yeah, it's
I
okay.
stop.
It's okay.
I stopped fighting with pathologists for this. So yeah, because I mean, of course, it's not a dysplastic nevus. It's not illogical because it's not the scenario of a person with multiple atypical nevi. It's not the age for this, so it is a melanoma in situ. But anyhow, since the lesion was excised in healthy margins, then that's okay. Yeah, and of course,
Probably harmless melanoma. He will never die because of this if it stays there for a long time. There are some harmless melanomas.
Exactly. Nothing bad is going to happen even if you don't do a wide excision to 5 millimeters or whatsoever. So it's disappointing, but it's fine. Of course, the same thing occurs even more frequently in some specific sites that we know it pretty well nowadays. So again, we're not frustrated. So you know that when you biopsy this lesion, don't expect a satisfying result. Don't expect that the pathologist will tell you melanoma in situ. It's very difficult in a case like this, in acral melanomas or in nail melanomas, to get the word melanoma written in your report. So it's very probable that you will get a result either of a nevus with atypia or a descriptive result describing a melanocytic junctional proliferation without naming this as a melanoma. But again, I'm not frustrated anymore.
Although in this particular case, the management is a little bit more difficult, because if you don't make sure that the lesion is entirely excised with a broader margin,
it's going to recur.
You get a recurrence.
It's going to recur. Yeah. And especially,
and this is a high risk area.
Yeah, in this scenario, it's also tricky to achieve negative margins, because this is the classic lentiginous growth, with poorly defined borders, and it's quite challenging.
I like the suggestion I see from Taha. Next episode, how to be a friend with your pathologist.
But that's what I'm trying to do, Taha. You see you see the words that they select to use. I mean, no fight. Yeah. Similar case. I mean, I remember I was almost laughing. I mean, look at this case. I mean, like 60 years old, dysplastic nevus.
No, come on.
But this is easier because at least it's rather well defined, so
well demarcated, so you can
well demarcated. Okay. Okay. Of course, same thing on the face. We spoke about it thousands of times. When you biopsy lentigo maligna like this, many times you're gonna receive a report which will be disappointing. Sometimes very disappointing when they use the word junctional nevus. You know that this is completely illogical. So I'm much more fan of these new terms that Jeppy doesn't like, while I love them. This IAMP, IAMP,
Yeah.
IAMP, IAMP. Yeah, You know what is IAMP, guys? IAMP stands for intraepidermal atypical melanocytic proliferation, that according to the WHO classification is the precursor of lentigo maligna. So
yeah, of course.
we found peace with the pathologist. Yeah, we found peace. Yeah. It's a precursor of lentigo maligna. I'm fine. I'm absolutely fine with this diagnosis. And on the face, also the management is easier because, as we discussed many times, we have the option of imiquimod as an adjuvant treatment, even if you cannot achieve a perfectly negative margins in your lesion. So,
as you can see, Jeppy is furious.
No. He's
No,
also
it's okay. I made peace as well.
He's also in the procedure of making peace. Now, another scenario that the result was pretty disappointing, and it happened to me more than once. Tell me if it happened also to you. I showed this case also last week as an unexpected result, because you remember the case that was looking like a BCC, but the result was eventually a melanoma. The disappointing thing here was that this was reported histologically as a 2.3 or 4, I don't remember, millimeter melanoma without ulceration.
Yeah, it's. I completely agree with you. I have many reports like that.
Yeah.
You see an ulceration, but pathology said that there is no ulceration.
Which, by the way, in this scenario is not only theoretical, it's also important, because a tip 2.3 with ulceration becomes a stage 2B, which has a possible
is entitled to adjuvant therapy.
Indication for
adjuvant exactly. Therapy.
So it's not irrelevant.
Yeah. Prognostic importance.
So, of course, here when we insisted and we showed the photograph and so on, and we explained why it's so important to make sure that there is an ulceration or not. In additional cuts, they found the ulceration. Of course they did. Yeah. But that's it's not the only case that happened to me. Probably we did not insist so much on this in the past because we did not have the scenario of the adjuvant treatment. Therefore, it would not make a big difference in management the years before adjuvant. It would still need a wide excision with sentinel lymph node biopsy, and that's it. Nowadays, it's important. It's important.
Yeah, but there is also one more thing is the fact that in pathologists have specific criteria to name ulceration present. It's not only the fact that there is no stratum corneum, but there must be something more. I don't know exactly the technical issue.
Complete loss of the epidermis.
Yeah, exactly. Yeah.
But the point is that imagine that the sampling of the pathologist is just a small percentage of the lesion. So in a lesion like this, it's, in my opinion, 100% sure that if they do serial cuts, they're gonna find a complete loss of the epidermis at some point. Yeah. It's impossible.
And because it also happens to me in basal cell carcinoma. You see an ulceration on the surface, but in the pathology report, it says that there's no ulceration, which is very common also.
Correct, but there you don't insist because it doesn't matter.
Yeah, it's not prognostic. Yeah, it doesn't matter. Yeah.
Here it matters not only because it's prognostic, but also for therapeutic decisions.
So,
but it's also interesting what you're saying, because in melanocytic lesions, by standard, they take more cuts. So in a suspected BCC, when you have BCC in your differential, they will take probably 3 or 4 slices. In a suspicious melanocytic lesion, they will take at least 10. Still, it's less than 1% of the lesion that we see. But they should be able to see it. But I agree with Emilios, if you're in cahoots with your pathologist, you can always go back to him and show him the image and ask him to do several cuts.
Yeah, but it's reasonable. And if, in my experience, if you explain to the pathologist, I mean, why you insist so much and why he has to be exhaustive with the slides, they understand and they're gonna
Yeah,
do it.
they do understand.
Yeah.
They do it. Yeah.
And I think that pathologists have become better on this while participating into, especially the tumor boards are so important in all this collaboration. It's the
Sure.
way that they understand the way we think, and we understand the way they think as well. So I think this is the most important development in tumor management.
So
Exactly.
let's change completely the scenario, but a very disappointing result. Very disappointing. That was a case of Zoe in her hospital. They had a clinical trial, ongoing clinical trial with a new drug for lupus. And they wanted to enroll to the trial this lady who was 29 years old, as you can see, with multiple erythematous squamous plaques on the face and the upper trunk, and with a confirmed previous personal history of discoid lupus.
Okay.
But yeah, come on.
Yeah.
New
What
lesions
else?
manifested, they look clinically, dermatoscopically, perfectly in line with the given history of a lupus. So they wanted to enroll the lady to the trial because she was unresponsive to the standard treatments that we have, which are anti-malarians and systemic steroids. So it was very important to be enrolled. But in order, one of the inclusion criteria for the trial was that you have to perform a new biopsy from one of the new lesions, and this biopsy has to be sent to the centralized laboratory of the clinical trial, which was somewhere abroad. So they did this, and the
Polycythropic
result.
mycosis fungoides, is that patient?
No.
MF?
The result was squamous cell carcinoma. And
Come
they
on.
and they got a second biopsy from another lesion, and the result was again squamous cell carcinoma,
No way.
which is completely
Out
illogical
of line.
and
Out of line.
also out of line, and also it's very well known, and it makes sense that there is a significant overlap in hypertrophic discoid lupus with well differentiated squamous cell carcinoma. They have so many things in common histopathologically, and definitely, in my opinion, in a case like this, the pathologist should seriously take into consideration the clinical context, which was so much indicative of lupus, of course. And that was a really frustrating scenario, because imagine, I mean, the lady was waiting for the treatment, and she had trouble entering the study. So that's literature suggesting what I told you. Another scenario, somehow similar, 75-year-old man with these erythematous plaques. You see that they are located on on exposed areas, forearms, arms, little bit on the cervical area, photosensitivity, no history of any disease. So no history also of any drug or anything else. So here in the differential, I guess, okay, theoretically lupus is in the differential, but look at the age.
Yeah, but also reticuloide actinico,
Dermatomyositis.
dermatomyositis, yeah, why
Of
not?
course, drug eruption, although there was no history of drugs. Yeah, several things. So definitely a case that merits to be biopsied. By the way, dermoscopy, that's dermoscopy, not significantly helpful. There is a little bit of hyperkeratosis, some vessels, but not really predominant. So not, to my eye, not really guiding to any definite conclusion.
Hyperkeratosis, parakeratosis, and nothing else.
So that's histology, which we can see these vacuolar changes of the junction, and the lymphocytic infiltrate, which is in fact somehow periadnexal and a little bit perivascular. So it is in line histology with two things, that are very much overlapping here, and these are lupus and dermatomyositis, because we have to remember that they are so much similar.
They're very close. Yeah.
So this patient received the report of lupus, and he was treated as lupus for a period without any improvement, of course. So he got antimalarials, hydroxychloroquine, without any improvement, of course. And then at a later stage, they decided to do further investigations to exclude the possibility of paraneoplastic dermatomyositis, and in fact, they found in gastroscopy gastric CA. So eventually, the diagnosis was restored as paraneoplastic dermatomyositis. And here the problem is that the pathologist should be very well aware of this, that the histological grading of lupus in skin biopsies is nearly identical to that of dermatomyositis. So it cannot be done on a purely histopathological basis, this differential diagnosis. It requires more.
Didn't she have myositis?
Yeah.
Muscle symptoms. Did she have muscle symptoms?
No. But it exists. It exists. Dermatomyositis without myositis.
Amyopathic,
Yeah. Amyopathic. So that's also a very important and disappointing result, which might happen if you don't have the overall, if you don't take into consideration the overall scenario. One of the last cases, I remember very well this case, patient with previous melanoma, a very easy for all of us. You see this lesion.
You're so passionate about this topic. Like you prepared the images and you're like passionate about it. I love it.
Look. You see 1, 2, 3, 4, 5, and that's dermoscopy. What are they?
Metastasis.
Metastasis. I mean, is there any other scenario? No. Diagnosis by an expert pathologist, not, thank God, not the ones that I collaborate here. Primary melanomas.
All of them, yeah.
I remember that at first we punched 2 of them. Then we got the report 2 primary melanomas. Then we punched 3 more primary melanomas. Come on. Why? Because they were the so-called epidermotropic metastases. So the ones that for some strange reason, they invade upwards the epidermis. They go up, and and just because they go up and they involve the epidermis, for a pathologist, it's really confusing, because they expect the metastasis to occur in the dermis and not in the epidermis.
Yes.
So they see the neoplastic cells in the epidermis, and they give this ridiculous diagnosis of 5 primary melanomas that occurred, in 1 week or 2.
So very important cases.
Yeah. And that's the last one. Very interesting case. You see here there is a flat part of that looks like, I don't know, a nevus or what. We cannot say about the flat one, but the nodular thing is pretty much suspicious. Of course, a lesion to be excised. So the cuts of the lower part reveal this, which is, as you can see, a junctional proliferation with some
atypical, whatever.
Yeah, you cannot say, at least, I mean, I cannot, if that's just atypical nevus or something more than this. And then the cuts here correspond to this, which I'm not a pathologist, but I've seen it 1 or 2 times, and that's enough. That's a clear-cut tumoral melanosis. That's a massive invasion of the dermis from melanocytes. And in fact, this was reported in the report of the pathologist, that there is a massive dermal infiltration. So that's what they say here. They say that in the junctional component, there is a mild atypia. In the other component, there is a very dense dermal infiltration of melanophages and lymphocytes. So tumoral
What did you
melanoma.
do? What did you do? This is
Wait
the
a moment.
important this.
Wait a moment. The description is nice. The conclusion was that it's a focally heavily pigmented compound nevus with mild atypia, and that's very disappointing. That's very disappointing because you cannot conclude that this thing eventually was fine.
Yeah.
You cannot conclude with this. You might conclude that we cannot say for sure because we don't see the melanocytes, we see only the melanophages, we can't say for sure. But come on, that's a melanoma and we know it. Anyhow, we cannot conclude that that's a nevus. We can conclude that we are not sure. Yeah, that's what I want to say.
So what was your approach, Emilios, for that case? Did you perform PET-CT or something else? For that case?
Approach it as a melanoma with a known thickness and
yes. So I don't remember if we performed the PET-CT. I don't think so. I think
or sentinel lymph node biopsy or something
no,
else.
sentinel lymph node biopsy. No,
guidelines.
No,
we performed CTs,
unknown,
not PET-CT. CTs and echography.
Especially
close follow-up.
The basic statement.
Close follow-up with ultrasound, especially if it's located on the extremities.
By the way, this is a very good point of discussion, probably. How do you follow up patients with melanoma? Like the guidelines speak very much about the more advanced stages, but you have a patient with a melanoma 2A, 1B. How do you follow them? How do you monitor them? This is a very good question that we haven't actually have enough clues, I think. Do you do ultrasound? And how good, if you have a good...
Well, the overall, I could take this one because in my view, it's clear cut that the situation changed dramatically in the last 10 years. 10 years before, it was really unuseful to follow these patients, the 1B and 2A, with a lot of TC scan and whatever, because there was nothing to do. So it's not relevant for the prognosis if you wait the symptoms of the recurrence or you diagnose them
Metastasis.
1 month or 2 months earlier. Why today it's relevant. Today is relevant. So for 1B, we do ultrasound only because, I mean, in general, if the few cases, recurring cases are going through the lymph nodes. For 2A, we add TC scan.
Yeah, but then for how long and how often, it's a matter of...
it's a matter of, we do every 6 months or every 12 months.
but this is so interesting. So I have a patient that was just diagnosed with a melanoma 1.9 millimeters with ulceration. But it's 1.9, so it still falls under 2A.
Yeah.
And I mean, what's the difference between 1.9 and 2?
Like 0.1.
Yeah, but
that's why 2A is a very critical stage because it's really in the middle.
Yes.
It's not in the group of melanomas going well. It's not in the group of melanomas going worse.
So
it's in the middle.
If we think about it, which is the real question we want to answer? The real question we want to answer is for these few 2A melanomas that are going to recur, and for the even fewer 1B melanomas that are going to recur, and for the even fewer 1A melanomas that are going to recur, what is our realistic goal? To detect the metastasis at the earliest possible stage. Can we agree on this?
Yes.
That's the goal. Okay.
Absolutely.
Okay, that's the goal, to detect it at the earliest possible stage. Okay, so then what kind of exams do we need to detect the metastasis at the earliest possible stage? It's impossible, guys, because you would need to do a total body
CT
scan
Yeah.
for
every
of
3
all of
months.
them,
No, but
of all
no,
of them to detect.
there are data. No, there are data suggesting that if 1A or 1B is going to recur,
It's going to be nodal.
to the lymph
Nodal.
nodes. It's going
Perfect.
to the lymph nodes. While if you have a 3, 4, 5 millimeter ulcerated thick melanoma with ulceration, it could be going hematologic and therefore
Hematologically.
scan.
Perfect. Perfect.
Yeah.
That's what I wanted to say. The only guiding sign we have is that for 1As and 1Bs, we know that the majority of metastases, especially the ones that occur late, occur regionally.
Yeah.
Therefore, we could conclude that for this subgroup of patients, it's enough to examine the lymph nodes with ecography, and you don't need to do anything more.
But if I may interject here, we have one big problem, at least in Greece. We have very few good echographers. So very often we reside to CTs because they're more sensitive to identify enlarged lymph nodes compared to like a regional person
We
that
get
has.
the opposite. We get the opposite problem. We have many false positives, not many false negatives.
Correct.
Yeah.
Correct. Yeah. No,
Same.
ecography theoretically is very good for this, but the problem is that it's a very user-dependent technique.
Exactly
Which,
that.
We need a good blood test for metastasis, like tumor markers, but still
but that's
good
the whole
blood
effort.
test.
The whole effort is to try to find biomarkers that will
Yeah.
spot those few patients that will recur. But until then, I mean, we don't have a clear guide.
Ragazzi, it's 8. Come on.
Okay,
We
great.
lost. We are going, discussing like this.
What do you have to do? What do you have to do?
An episode. This is a show. We have to keep going with the timing. Come on.
Okay, so I will not show my cases
No, what?
because
Show.
no, there's no reason because they were all in line with yours actually, Emilios, with only one addition, just descriptively. One, disappointing results, and not histopathology. You see on dermoscopy the mite of
Kebis.
scabies,
And it's negative.
and you send it for scraping. You mark the area and you get a negative result. Reside dermoscopy. They are wrong. They didn't scrape correctly. One.
But for this there is a solution.
What?
You don't send it. You don't send
do
it.
So yes, but I changed my practice after getting 2 or 3 negative results, whereas while I was seeing the mite there. So this is one. You don't send it. 2, fungal infections, which are clear cut, clinical and dermoscopical, and you send them and they scrape off and they see no evidence of or no development on the Kaleria
Culture.
Culture.
on the tissue culture. Come on, guys. Okay, maybe the patient has applied some moisturizers. Maybe he has scraped off from the wrong point. If it's clinically relative, just treat. Terbinafine works great. And the other one, of course, and the others are, as Emilia said, melanomas in situ versus junctional nevi, etc. The only thing that I want to share, very similar to Emilia's case, is this one. So this is a lady, 50 years old, that has this lesion here, heavily infiltrated, and she has had a biopsy. It turned back actinic keratosis / squamous cell carcinoma in situ. She received
Discoid lupus.
cryotherapy 3 times, imicumod plus 5 FU, and the lesion, of course, just erupted and stayed exactly the way it was after a bit, and you put
Really?
dermoscopy on.
Really, yeah.
This is the DLE, and we applied corticosteroids regionally. And of course, within 2 weeks, it was resolved. So
Yeah.
always keep in mind what Emilius was saying, that DLE and AK are very similar in histopathology. So, like, a short course of corticosteroids never hurt anybody, even if it is AK. Who cares?
Yeah.
Just do that.
Wonderful. Wonderful.
Absolutely.
Great. Can I show you Daria?
Go ahead.
Can I show you Daria?
Yes,
Please.
please.
Great cases as usually. Let me show you. Here we are. Okay. Stop share. Share. Area. Here we are. Okay. Oh, come on. Just a moment. Oh, almost. Okay. So here we are. We have case number 1 and 2, annular lesions. Patient 1, patient 2, clinically.
Females.
Lichen.
Lichen, yeah.
Yeah, okay. But patient number 1 has what? Come on.
What's that?
Necrobiosis.
Necrobiosis.
Necrobiosis?
But why?
Necrobiosis. But
Necrobiosis lipoidica.
Yeah, but why?
Vessels. Look at the vessels.
Look at the
type
vessels.
1 diabetes.
I agree with necrobiosis lipoidica, but my confusion is a 7-year-old female. Why?
7? 7, yeah.
Type 1 diabetes.
Yeah.
Maybe.
Diabetes, yeah.
Most likely.
But look how beautiful is these vessels showing the blood cells going through the vessels. Look at this.
Yeah. Wow. That's
Unbelievable.
amazing.
Show you again. Unbelievable.
Yeah.
Beautiful.
Okay, patient number 2.
Lichen.
Lichen, okay.
Oh, no.
Lichenitis.
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 No.
No.
No?
No.
Wow.
Granuloma anulare. Okay.
Granuloma anulare.
Okay.
Yeah. Okay.
It's okay.
Yeah. Understandable. Okay.
Yeah.
Number 2.
BCC.
And?
BCC and?
Poroma. Okay. Patient number 1. BCC.
Yeah.
BCC.
BCC. Easy.
Yeah.
Easy.
Yeah. Easy. Clear cut.
Patient number 2.
Poroma.
BCC.
BCC.
Poroma or BCC?
BCC.
Poroma
There are
or
main
Poroma.
globus.
Poroma or BCC?
No, this is BCC. Poroma like vessels, but BCC.
Okay. BCC. Good.
Right.
Wonderful. Question number 3, patient 1 and patient 2. Patient 1.
Eczema.
Granuloma anulare.
You know that we call it eczema marginatum of Ebra.
Wow.
What is that?
Yeah, tinea.
Tinea.
Yeah. This is tinea.
Look at the
Tinea.
pustules, this is easy.
Pustules. Tinea.
Beautiful.
Tinea from
Beautiful.
probably from microsporum.
Yeah, could be. Yeah. And you see the eczema plus the pustules.
Yeah.
When you see
Yeah,
the
this is a
pustules,
great case.
It's easy. Yeah.
Yeah.
Wow, beautiful.
And patient number 2?
Eczema.
Granuloma anulare.
Granuloma anulare.
Granuloma anulare.
Yeah.
Interstitial.
Yeah.
The palisading.
Orange color, some vessels, even more than expected in granuloma anulare, but
Much more.
yeah, but that's it. Thank you, Daria. Wonderful.
Who remembers Darya's city? Who
I don't
remembers the
Gioxarole.
Amelios? You remember?
Gioxarole, something like that.
Okay.
Penelope time. Let's go quickly. Case number one.
Penelope.
Quickly, but not so much.
LPLK.
52, blah, 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 recent time, cheekbone. Yeah.
LPLK.
Yeah, should be. Should be LPLK, I agree. Evident follicles, granular pattern. Okay. Accepted.
Within the same realm.
Yeah.
Yeah.
Wonderful. Face again. Past history of numerous blah blah blah. Larger lozenge palpable right orbital patch for some time. Okay, che bello, but it's not so nice. Well, very optimistic.
Well, but there are mixed
Collision.
pattern.
Collision.
SEPK and BCC.
Guys, concentrate.
Solar Lantigo and Lantigo maligna.
Concentrate.
Yeah.
Lantigo maligna.
I still think it's
And
BCC.
solar Lantigo.
Yeah. Okay. But definitely it's suspicious for melanoma, no? Yeah.
Yes.
Solar Lantigo BCC. Yeah.
Unexpected or expected result? Well, depends. If you say BCC, it's unexpected. If you say melanoma, zigzag pattern, okay, yeah, rhomboidal, black blotch.
Lantigo maligna and solar Lantigo.
Maligna, perfect. 1.1. 1.1.
Okay.
That's a surprise.
That's a surprise, yeah.
That's a surprise. Okay, because of the blotch, I would expect micro-invasion, but not 1.1.
True.
Yeah, it's very thick.
Okay, soul, 27, subpigmented lesion on the soul.
Okay. Beautiful.
You like it, eh?
Yeah, I like it. It's a nevus, yeah.
It's a nevus, are you sure?
Well,
It's that.
well,
It's Pascal. So
yeah. Never say
Atypical spitz tumor, no.
Oh,
come on.
wow. Really unexpected. Really unexpected.
Yeah, really unexpected.
Yeah.
Absolutely.
Okay.
Wow. Okay, 63. Pink, 1 year. Okay. Come on.
Poroma.
Poroma, of course. Now we know. Poroma. Why not? Expected or unexpected? Well, if it's Poroma, it's expected. If it's BCC, it's going to be unexpected.
Melanoma, it's highly unexpected.
If you say melanoma, we
we give up what we do.
We give up, exactly. Tortoise complex, happy. Yes!
Yes.
Poroma, very good. And the last one, nail, longitudinal melanonychia. Okay, that's dermoscopy.
Traumatic.
That's the frontal view. You see a little bit of hyperkeratosis subungual. Expected or unexpected? Come on, don't say melanoma.
Pigmented onychomatricoma.
Don't say melanoma, and we are fine.
Yes, as long as it's not melanoma, we're good.
If it's not melanoma, we are good.
Pigmented onychomatricoma.
Distant onycholysis and subungual hyperkeratosis. Subungual squamous cell carcinoma in situ Bowen's disease.
Yeah, I don't believe it.
Mamma mia.
Wow.
No, I don't believe it. I would challenge the pathologist very hardly on this one.
First of all, in order to challenge the pathologist, you have to arrive to the point that you have sent something to the pathologist.
Yes, I would never, yeah.
Okay, very good. Wonderful. Perfect. Thank you so much, Penelope.
Great cases, as always.
And Konstantinos, are you ready for the Kahoot? Do we have it?
Absolutely.
I gave up the Kahoot after last week.
Well, let's see how I did.
I was, they don't allow me anymore to take care of the Kahoot. So
Okay.
Get ready to join. No sound?
I haven't said sound, sorry.
it's okay. It's okay. It's okay.
Okay, don't worry, don't worry.
In the meanwhile, we might want to remind our friends all over the world that next week we are not going to be here. We're going to have a 1 week break for a very important reason.
For a very good reason.
Much more important than the Eastern break that we did recently.
Of course, and Christmas as well.
And Christmas as well.
Yeah.
Very, very important reason. Because we will all be in Napoli, including all the audience. I mean, we said that
Of course.
Jeppe has booked
All the audience is invited to Napoli.
to Napoli. Jeppe
All
has
the
booked
audience.
To say
the
happy birthday to
The
me.
stadium.
Napoli Stadium. The Napoli Stadium is fully booked
Yes.
for his
Napolitano.
for his 30s, the birthday of his 30s.
The 30s. I cannot recall my birthday party or when I was 30.
Because you didn't care back then.
No, because if you cannot recall, it means that you enjoyed a lot.
Go.
Male, 52 years old, comes in for a new and changing lesion on the back. And this is dermoscopy.
Yeah, of course. Then they want you to make. I understand. Yeah, of course. Of course.
Is this a congenital nevus, a junctional dysplastic nevus, a melanoma inside or an invasive melanoma?
Okay. The next one is going to be an angioma with beautiful lacunas. And is it an angioma or? Yeah, come on.
Okay, most people found it
But you
correct.
see that some people were influenced by our discussion today. They
Yes,
for junctional
junctional
dysplastic nevus. Yeah.
Dory is on the lead, then Mustafa, not easy, lone wolf sign, and Mimi. Of course, here it's exactly the case that Emilius was describing before. If you get back the description of a junctional dysplastic nevus on this one, just don't believe it. This is a melanoma in situ. What we see is network alone, so we're talking about junction above and some regression in the forms. Actually, this is something that hasn't been published, Emilius. So far, regression is peppering and scar-like depigmentation. But this subtle depigmentation hasn't been very strongly in the literature.
Mm-hmm.
And of course, we're talking about the Tyndall effect. We're talking only about brown and dark brown. So this is, of course, a melanoma in situ. 76-year-old male presents with this lesion on the forehead, history of 4 years. And this is dermoscopy. And what's your diagnosis?
Come on.
Is this a SEB-K, a pigmented BCC?
That is a scandal. That's a scandal. This is manipulation of the audience.
You want to win easily, eh? Come on. It was not so easy.
Yeah, because they cannot believe that you so easy cases. So they think that there will be something hidden.
Not easy is on the lead.
Not easy, yeah.
Then Argentina. Joe, LA, and Lone Wolf sign. And of course, the reason that we have an LMM is the obliteration of hair follicles here. So it's a microinvasive lentigo maligna. And moving forward, You're presented with the following histology image. To which condition does this correspond?
Oh, che bello.
Oh, nice,
Now we move to histopathology. Yeah,
Of course.
yeah,
What's your
yeah,
diagnosis?
yeah. Beginning with
Is this lichen simplex, B-cell lymphoma, psoriasis, or atopic dermatitis?
wonderful. I like this
really,
question.
yeah, really difficult. I mean,
Emilio,
extremely difficult. I mean, I
stop
cannot.
grudging. Stop grudging.
Yeah.
Grande, grande. You
Eh,
see, you got better results here than the case before. Can you imagine? Yeah.
And we have a change again.
Argentina.
Argentina is on the lead.
Argentina.
Then LA, RT, Lola, and Jonah. So we see parakeratosis and these elongated dermal papillae, which correspond to psoriasis. Female, 24 years old, with a history of psoriasis, presents with disease exacerbation. How is this phenomenon called on this new tattoo? Emilio is curious.
Rose tattoo sign.
Is this called Kebner, Pathology, or Nikolsky?
Well, you should say Kebner, Argenziano, Llopiri, Sakai, or Lala.
Yeah. This is Darie. This is Darie.
Daria, yes.
Yeah.
Nobody knew it.
Excellent. Argentina is still on the lead.
Argentina.
Lola, LA, and MBY.
Argentina must be very young because it's very fast.
Okay. Female, 52 years old, presents for evaluation of a new lesion on the thigh. History of 2 years. And this is dermoscopy.
Okay.
Ah, okay.
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 And this is non-polarized dermoscopy.
Okay.
What's your diagnosis? Is this a melanoma in situ, invasive melanoma, clonal sub-K, or pigmented BC?
Hai capito. Hai capito.
Okay, Emilius now?
Okay, 1 out of 5 was acceptable.
Great, great, great.
Okay, but nonetheless, people went great.
Yeah.
This is indeed a clonal set K. We can see that Argentina is still on the first place, then LA, Jonah, Lola, and MBY.
You have more?
And here on the non-polarized, we can see the blue structures that are very corresponding to clonal seborrheic keratosis. Also, we can see the very fine delineation, which corresponds to a seborrheic keratosis. Male, 72 years old, presents for this changing lesion on the trunk. And this dermoscopy.
The fact that it's changing is changing my mind.
What is the expected breast load then?
In situ. That's in situ.
Well, I mean, not easy between the last two.
What do you mean not easy? 5 millimeters, 6.
But the next question is this is the dermoscopical image and 4.2
Yeah.
ulceration positive, SLN 0 out of 3, staging negative. What is the stage?
This is a nice question.
Finally. We should do an episode on this then.
Yeah,
Yes.
yeah.
Yes.
Okay.
So, Argentina is still on the lead. Then Lola, Jonah, MBY, and SG. Just a quick reminder. So this was a 4.2 millimeter. So T4, ulcerated, T4B, N0, M0. So accordingly 2C. And I think that we should conclude here. I don't think that we need to do this one as well. Argentina is the winner.
We stop like this without the podium.
We stop like this.
Okay.
Yeah,
Okay.
okay. Good.
Okay.
Yeah, I mean, it's okay.
Argentina.
Argentina is the winner. Great.
I'm happy, I have to say, because I have a predisposition for Argentina, as you know. Special love.
Who is Argentina?
Grande. So let's
Alberto. You are banned from now on. No, of course not. Of course not.
No. We gave minus something, at the beginning to him. Wonderful, guys. So no episodes next Sunday. So we will continue on the following Sunday for 2 more Sundays. Yeah, it's almost finished for
It's almost done.
Yeah, almost done. Great.
So you're gonna miss us next week. I hope we're gonna miss you too, but it's for a good cause. Therefore, send all your love to Jeppy for his birthday next Sunday. Remember to do it. Remember. And
Thank you so much, Jeppy.
Va bene, ragazzi, un bacione. Enjoy.
see us in 2 weeks.
See you in 2
Bye-bye.
weeks. Bye.